And welcome to our Pediatric Nephrology Fellowship webinar. Today, we have very interesting webinar. We'll be focusing on clinical tips and tricks for fluid and electrolyte management in our pediatric patients with kidney diseases. I'm Professor Amr El-Husseini, Professor of Nephrology, and I'm the Vice President of the World Kidney Academy. We have Dr. Shaegan Irusen from South Africa, Cape Town. He's a pediatric nephrologist and interested in pediatric critical care nephrology. Our guest speaker is Dr. Detlef Böckenhauer from Belgium, and I will let Dr. Neveen Soliman to introduce him shortly. And we also have Professor Vandrea Souza, Professor Ali Asghar, and Dr. Sidharth Kumar, who are going to moderate today's session. As you see, 7 people between moderators and the speakers and panelists, and they are from 7 different countries and 4 continents. This is what we are focusing on, the diversity in our program. So I'm giving you just a brief introduction about the Pediatric Nephrology Fellowship. Then Dr. Shaegan is going to give you samples of the pediatric nephrology materials. Then we will have our guest speaker to give us about 30 minutes presentation on fluid management and electrolyte balance in our pediatric nephrology community. Then I will let Professor Ali, Professor Vandrea, and Dr. Sidharth to moderate the session, and the closing remarks will be given by our organizer of this webinar, Professor Neveen Soliman. So we started our Pediatric Nephrology Fellowship last month. It's structured as 3 modules, 16 weeks each, and we endorsed our fellowship both by the IBNA, the International Pediatric Nephrology Association, and the European Society of Pediatric Nephrology. And because we all know that our memory is limited and our retention rate of the knowledge is also limited, we try to avoid giving one-way direction lectures or just depending on reading, but we are focusing on discussion and how to apply the knowledge to our clinical practice. So please remember this learning pyramid, because the worst you can retain is from the monologue or the one-way direction education. This is the reason that we focus on this fellowship on the dialogue more than the monologue, and we are delivering this scientific materials through a smart platform with a lot of critical thinking, questions and answer, evaluation and assessment, and also we are gathering a panel of international expertise. It's a wholly online fellowship program, and it has also live webinar, workshops, and video conferencing. And we are delivering the material through the smart platform every Monday morning, and the fellows will have the freedom to navigate throughout the whole entire material during the week. Then they need to turn their assignments by the end of each week. Again, there would be weekly quantitative and qualitative evaluation to our fellows. The first module is focusing on the renal physiology, the congenital anomalies, and tuberointerstitial metabolic disease. So this is for 16 weeks. Then the second module is focusing on GN, primary and secondary GN, and also vascular and other glomerular diseases. And the third module is focusing on AKI, CKD, dialysis, and the renal transplantation. Again, we are trying to help you to be an expert in the field and to graduate from a trainee and the mentee to a trainer and the mentor level. And also our fellowship is accredited by the American Association of Continuing Medical Education. Again, knowledge has no value until we put it in practice. And the great aim from education is not the knowledge itself, but the action. And with that, I'm going to stop by here and let Dr. Shaegan to give you some samples from our fellowship. And after that, Professor Neveen Soliman is going to introduce Professor Detlef to give us his great talk. Dr. Shaegan, go ahead, please.
Hi, Prof. Amr. I just want to check. Can everyone see my screen?
Yes.
Okay, good evening, everyone. Thank you once again for attending our webinar. My name is Shaegan Irusen. I'm a pediatric nephrologist, and I'm presently working in pediatric critical care. I'm working at one of the big hospitals in Cape Town, and I'm affiliated to the Stellenbosch University, and also proud to be part of the World Kidney Academy board. So I'm just going to give a brief overview of our pediatric nephrology fellowship. Some of it will be repetition, but I'll try and go through those areas as fast as possible. And I will just show a bit of the learning material that Prof. Amr has highlighted for all of us. So as said, so our pediatric nephrology board, not all our colleagues are here at the moment, but we do have a diverse representation from many colleagues from across the planet. Which I think is very exciting. And many of these are leaders in the field of pediatric nephrology. So learning from them is something that I think is very important and something that we can all benefit from. So as Prof. Amr has said, it is structured as 3 modules with 16 weeks each. And I think importantly here, it is designed as 1 lectures, journal clubs, multiple choice questions, and clinical case scenarios that I'll show everyone shortly. So the important thing, I know everyone's busy, and you know, often educational programs like this are often done in our own time, away from the bedside and away from clinical practice. So importantly, everything is asynchronous, so people can do this individually at your own time. Lectures are pre-recorded, and there's lots of the journals are generally guidelines and published in high impact factor journals. So that you know, we know it's coming from credible sources. There are real life case scenarios that can be discussed. And I think importantly, once you become a fellow of the course, everyone is invited to join the WhatsApp group where you are free to discuss, ask clinical questions, and have direct interaction with the trainers on the course. So collaboration, I think, is important as well. So we just need to know where we're coming from. Importantly, I've highlighted IPNA, which is the International Pediatric Nephrology Association. And we recently, last weekend, in fact, had our biannual conference here in Cape Town, which was fantastic. And I was so grateful to meet many of our colleagues. But it is endorsed by them, as well as, for example, the European Society as well. And we're looking at growing this and getting endorsements from around the globe. So as spoken about, we have different modules. As you can see, it is quite structured with 1 week is a per mini module, giving all candidates the chance to complete the areas of interest over that time. So this can be done completely when you have some time, you can break it down. So there's not that pressure to complete everything as you go along. And as you can see, we touch on different things, and some of the lectures are introductions and others go a bit more in depth. As you can see, this is module 2 with our glomerular and vascular disorders, and onto renal dysfunction and kidney replacement therapy. So we touch on the basics, we revise the physiology all the way onto therapies that are necessary for patients with kidney disease. So here's an example from multiple choice questions. This is from one of the modules that is in the pediatric fellowship. So this is an 8-year-old child with acute renal dysfunction. That has a medical history of nystagmus at birth, hypertomy, developmental delay. The urine microscopy is relatively unremarkable, and the kidney ultrasound shows hyperechogenicity and loss of corticomedullary differentiation. So whilst many people who do this may not know the answer, but there are a few options there, and in this case, the correct answer would be genetic testing. And importantly, what is shown is that there is an answer that is given. So there is an explanation with references so that whoever's doing the module can see how we as the examiners would like you to think through the thought process. So this here is one of the articles that I referenced in one of the lectures. And unfortunately, I haven't been able to make the video play, but this is a review article published in the American Journal of Kidney Disease on cystic kidney disorders. And this is one of the tables that is there, and I'm giving this lecture in the module itself, and I reference this here to try and teach you how to have an approach on cystic kidney disease. Then we move on to the Journal Club. Another article is provided. The full article is available for download. Again, published from a high impact journal that covers all the basic topics on what is a rather large topic to go through. And again, a question. So a 5-year-old male reviewed in the clinic, in the kidney clinic. The parents give a history of polydipsia, and the urine is very light. They're concerned that she may have diabetes, as they've been reading up on the internet. The dipstick is fairly normal with no abnormalities. The kidney ultrasound shows bilaterally enlarged kidneys. And so regarding nephronephrosis, which is incorrect. And there are a few options for you, and we go through the answer, again, with an explanation with the reference telling you where to find the answer. And then finally, I've taken this here as one of the clinical case scenarios from another one of our fellowships. This is from the Critical Care Fellowship. So again, asking a question, in this case, about an adult patient with lupus and hypertension who presents to the ER with a lactic acidosis, and a transaminitis, started on appropriate antibiotics and cultures are sent. The patient receives some fluid. The blood pressure still isn't great with an elevated heart rate. The patient is weighing at 113 kilos, but still drowsy. And we want to know what is the appropriate management. And if you look here, this is what it'll look like on the fellowship itself. I've taken the screenshot from the website. It is highlighted in green because I've selected the correct option, discussing it, and again, explanations with references. So as I've said, we are presently busy with Module 1 for all our candidates. Module 2 will be kicking off around April, at which point people who are interested can sign up for the fellowship and do Module 1, again, asynchronously. There is a discount code that I've put on the screen. This offers a 10% discount to those that are interested. And if you have any questions, I would really encourage you to get in contact with us so we can just give you a bit more information. Prof. Amr, that's all from me, and thank you very much.
Thank you so much, Dr. Shaegan, and I will let Dr. Neveen to introduce our guest speaker. Please unmute yourself, Dr. Neveen.
Thank you very much, Dr. Amr. Thank you very much to all colleagues. It's my pleasure and honor to introduce Professor Detlef Böckenhauer, Professor of Pediatrics and Pediatric Nephrology, who used to be in University College of London, and now he moved to Catholic University of Louisville, and we'll be looking forward to hear from him about the clinical pearls in fluid and electrolyte. So the floor is yours, Professor Detlef.
Thank you. Let me see if I can share. And can you see?
Yes.
Yeah, and you can hear me as well.
Sure.
Excellent. Okay. Well, hello, everybody, and welcome to this talk. So I am interested in tubulopathies. Let me just come on. Yeah. And here just a brief introduction to kidney function, maybe a little bit too basic for you, but I think it's always nice to come up with the basics first. This is a slide that I have downloaded from Kidney Research UK, which is a charity that promotes kidney research in the UK, but it also provides information material for patients. And this is a slide that is meant for patients to explain kidney function. And you can see the dirty blood that's going into the kidneys, and then it goes through these super filters that clean out all the waste products that then leave through the ureter here at the bottom, and the beautiful clean blue blood goes back to the body. It's marvelous, isn't it? But not a single word about tubules. And from a tubular view, of course, these super filters are only a small appendix here to this whole structure, which we call a nephron, and which mainly consists, obviously, out of the tubule. And from a tubular view, these super filters are really super stupid, because all they do is they throw out a lot of bath water. And it truly is bath water because it's the extracellular fluid that's being filtered. So it's the fluid that bathes all our cells. And in that bath water are a lot of precious little babies. So first of all, how much bath water is being filtered? Think about it. It is, of course, the GFR. So if normal GFR is around 100 mLs per minute, that would be 6 liters per hour. This would be 144, or roughly 150 liters per day. 150 liters per day being thrown out by these super filters. And the precious little babies in there, well, the sodium in there alone is equivalent to more than a kilogram of salt. And then there is amino acids, small molecular weight proteins, sugars. And again, it's just all thrown out there. And who needs to clean it up? Well, the tubules, of course. So without your tubules, you would pee and thus would have to drink 150 liters per day. You would have to eat more than a kilogram of salt. Just think about the last time that you went to the supermarket to buy some salt. You're all throughout the world, so I don't know how it is in your country, but here in Europe, you typically buy it in 500-gram packs. And I don't remember I bought the last pack because it usually lasts for months. But here now, I would have to eat more than 2 of them per day in order to keep up with the losses of these super filters. And all the sugars, amino acids, and so on that would be thrown out. So all that is cleaned up by the tubules. And this is a slide that's more appropriate for in-person seminar, because in an in-person seminar, I always try to say, this is how the seminar would look like without your tubules. Because if you're peeing 150 liters per day, average maximal bladder volume of an adult is 500 mLs, you would have to go to the toilet 300 times per day. That would be more than every 5 minutes. So the only way you could have a seminar like this would be by doing it like Mr. Dury here with his bandmates on the toilet. So just to bring home how important tubular function is for our daily life. And if you think about it, that really is a very strange way for our kidneys to get rid of waste products. Think about how you get rid of waste products in your own house. You collect them as they occur, you put them in the bin, and then at the end of the collection period, you put the bin out and it's collected, and that's it. Simple, easy. But if you were a kidney, you would do it much more complicated. You would take a giant fire hose and flush everything out of the house, everything that's small enough to fit through the windows and the door. That would be the pore size of the glomerular filter, so the big wardrobe and the bed, and so that stays behind. But everything else, your crockery, your cutlery, your books, your little things, it will be all flushed out into the front lawn. That would be the tubule. And then you employ an army of highly specialized robots. Those would be the tubular transporters. One that would pick up the forks, and the other one that would pick up the knives, and the other one that would pick up the CDs, and so on. And they would bring it all back into the house, make sure it's in the right place, in the right number. And at the end of this enormously complicated process, you would then have the empty banana peel, the empty yogurt cup, the old newspaper still lying out in the front lawn. So that's the waste products that need to be excreted, but everything else would be back in the house. An enormously complicated way of getting rid of waste products. And how did we get to it? Well, it's of course evolution. Evolution started in the ocean. And when you live in the ocean, it makes perfect sense to use filtration to get rid of waste products, because you're not worried about losing salt and water. You're living right in it. And of course, the salt with the ocean water with its salt in there was then also used by evolution to build up the excitable cells, that you can use the electrolyte gradients across cell membranes to get electrical currents, that your heart can beat, that your muscles can move, that your brain can think. But when life moved on to land, this was only possible because we developed ever more powerful tubules that maintained this ancient ocean environment within us so that still our excitable cells could work, and that minimized the losses from the filtration process to get rid of waste products. And so our tubules constantly adjust urine volume and composition to match the intake. That's how they keep us in balance. That's how they maintain this internal milieu, which mirrors the ancient ocean environment with us. And if you want to read more about this, then of course, this is your Bible, From Fish to Philosopher, from Homer Smith, the godfather of renal physiology. And in this book, which is freely available as a PDF on the internet, he describes how this evolutionary pathway of the kidneys occurred, and how much the tubular function and the maintenance of the internal milieu enables us to move a muscle, walk around, have a thought, be a philosopher. And if these tubules do not function properly, if one of these transporters is defect, then of course you can have very serious abnormalities in this internal milieu. And here are these highly specialized robots, these tubular transporters. You're all familiar with these different segments of the nephron. And don't worry, I'm not going to go into too much detail here. I'm just going to point out the sodium-potassium ATPase that is at the basal lateral membrane of all these cells, and which maintain this electrochemical gradient for sodium, which then drives most of the transport processes. For instance, co-transport with sodium, such as glucose, sodium glucose co-transport or sodium phosphate transport, exchange like sodium hydrogen exchange, or these other co-transporters. So most of the transport processes that occur in our tubules are driven by the sodium potassium ATPase and the electrochemical gradient for sodium and potassium that it builds up. And of course, if one of these transporters is broken, if the robot that brings in the forks, for instance, is broken, well, then you will have very little forks left in your house and a lot of them out in the front yard in the urine. And when we see a patient with a tubulopathy, then of course what we do is we mostly look at the electrolytes in the blood and the electrolytes in the urine and this clinical state. And from that, we try to deduce which of these specific transporters is broken. And when I still worked at Great Ormond Street, we had our tubular clinic on a Tuesday morning. And every Tuesday afternoon, my telephone would not stop ringing. And it was always the lab who was calling about abnormal lab values, mostly potassium. And that's because these highly abnormal lab values are also called panic values. They are so severely abnormal that lab protocol doesn't allow to just put it on the internal server and trusting that I will review them in time. No, they want to make absolutely sure that I receive these highly abnormal lab values in time in order to react to it and correct this. Okay. Now, again, tubular clinic is on a Tuesday morning, so I get a lot of these panic values in the afternoon. And this is just how do we usually get our normal ranges for electrolytes? Well, it's just the distribution in the general population. So if you're looking at sodium, potassium, chloride, whatever, you measure it in a lot of people and you get this Gaussian distribution, and what falls within 2 or 3 standard deviations is considered normal, and what's outside is abnormal. And when it comes to electrolytes, then with intact tubules, you typically fall within the normal range. But if you have broken tubules, then very often you will be outside this normal range. You will be beyond 3 standard deviations from the average. And I have kept my own sort of tubular wall of fame, where I've noted the most extreme electrolyte abnormalities that I've encountered in my clinical practice. And you can see there is a lot of room to panic in there. But of course, if you get a lot of these panic calls, if this is your daily bread, if in London, I mostly saw tubular patients, so I saw all of these electrolyte abnormalities, you do get a little jaded, and you're not panicking about a potassium of 1.8 anymore. And in fact, I'm asking myself, if somebody has chronically low potassium of 1.8, is that really such a problem? Of course, if I start out with normal electrolytes and normal tubules, and all of a sudden I go down to a potassium of 1.8, then probably I will be in serious danger. But if it's an acute change, that will be dangerous. But if I have a tubulopathy and I usually live around this potassium, is this really a problem? And in fact, I always like to teach the trainees that the more extreme the electrolyte abnormality, the more they should relax. Lean back, have a cup of coffee, think about it. And of course, if your sodium is 200 or your potassium is 1.0 or so, it's very difficult to do that. But my point is that if you have such a severe electrolyte abnormality, the only possible explanation is that this is a chronic problem. If you acutely go from normal sodium to a sodium of 200, you will be dead. If you acutely change from a normal potassium to 1 or 1.0, you will probably be dead. So the only way a patient can be living with those serious electrolyte abnormalities is that they have been chronic, that they have been developing over a long period of time. And probably the worst thing that you can do is to acutely try to change this problem. So to acutely bring down the sodium back down to normal, to acutely bring up the potassium. This is, if it's chronic problem, it's much better to also treat it chronically. And the other reason why I'm not so fussed about it anymore is, of course, because many of these problems, like potassium in a patient with Bartter syndrome, for instance, is very difficult to fix. You cannot just give some potassium and it's done, because it will be just excreted in the urine again. It's like filling a bucket with a slit on the side. The more supplements you give, the more expensive you make the urine, because it's all excreted in the urine. And patients actually, in my experience, have sometimes learned to manipulate these results. I once did a second opinion on a patient with Bartter syndrome, I think a 3-year-old boy. And in his local hospitals, the doctors had determined that if the potassium was less than 3.0, he would need to be admitted for IV potassium administration. And the parents hated that. And they had figured out that if they give him his oral supplements roughly around 30 to 60 minutes before the blood test, then his potassium would typically be above 3. And then his doctors would be happy. They would clap themselves on their shoulder. What a fantastic job we are doing in keeping the electrolytes in the normal range. The patient would not need to be admitted. The parents could go home. The child would not need an IV, and everybody would be happy. But of course, by the time the patient is home, the potassium is already well below 3.0 again. But we're not seeing it, we're not testing it, so we're not fussed about it. So the electrolyte values are very much dependent also on the timing of the last electrolyte supplementation. But then, of course, I'm asking myself, am I just becoming jaded? Am I just becoming complacent? And is this really not such a big problem if you have these electrolyte abnormalities? And I've really started to think about that quite a bit with a recent case. This was a 15-year-old boy who was previously fit and healthy. And he presented to his local A&E. A&E is British, that's the emergency room in American, with cervical lymphadenopathy. And bloods were taken mainly, of course, to look at the full blood count, but they also did electrolytes, and he had a potassium of 2.6 and a magnesium of 0.55. And as soon as the doctors received the panic call from the lab showing them these low values for the potassium, all hell broke loose. So this boy who had been sitting in the waiting room for 6 hours before, all of a sudden was immediately brought up to intensive care, and a central line was inserted. Massive doses of potassium were given to rescue him and correct these abnormal values of potassium. And eventually these IV corrections were changed to oral potassium and magnesium supplements. And because the doctors were very conscientious, they said, well, we better see you in a week to make sure that these are all fine. And of course, when he comes back in a week, these levels are low again. And then the supplements get increased, and he comes back in a week, and they're low again, and they're increased. So he has these repeated visits, and as in this time also, he now becomes severely symptomatic. He has chest pain, he has cramps, he has fatigues. First, he is unable to do any exercise. So his supplements are successively increased because, again, his blood tests always show hyperkalemia and hypomagnesemia, until eventually he's receiving more than 50 tablets of electrolyte supplements a day. And despite these industrial doses of supplementation, his symptoms only seem to get worse. Now he's not only unable to do any exercise, he's actually unable to go to school any longer, and has a dramatic fainting episode in front of his parents at home. Now, this was all at a local hospital, and we were only involved by telephone, but eventually then he came to clinic, and I was really very curious about what I would see there. And I was pleasantly surprised when he came in, walking in himself, and actually a very bright boy, fully engaged, listening, asking questions. He has his laptop with him where he makes notes, corrects his mother if she makes some minor mistakes in the history, has a completely normal examination, has this normal, if low normal blood pressure, and these are his electrolytes. So you see hypokalemic, hypochloremic, metabolic alkalosis with hypomagnesemia and hypocalciuria. This is not an interactive lecture right now, but think about the diagnosis. What could this be? And the answer, of course, is that's textbook Gitelman syndrome, right? Hypokalemic alkalosis, hypomagnesemia, hypocalciuria, that's textbook alkalosis. Indeed, we can confirm it by genetic testing. He has 2 pathogenic variants in the underlying gene SLC12A3, which encodes the sodium chloride cotransporter in the distal convolute. And just a quick delve into his electrolytes. Look at his fractional excretion of sodium. This is a salt-wasting tubulopathy, and yet his fractional excretion of sodium is 0.1%. And the reason for that is sodium is what our kidneys use to maintain volume homeostasis. You cannot lose constantly more sodium than what's coming in, because then you will die of hypovolemia. And if you have a defect in a salt transporter, like the sodium chloride transporter here, in the beginning, you will lose sodium, just like when you start a thiazide, it would be the same effect. You will lose sodium, your volume will contract, and as your volume contracts, the kidney now upregulates all the compensatory mechanisms in order to reabsorb all that sodium that's not reabsorbed by the defect transporter. That's why you get the hypokalemia, because you not only have upregulation in the proximal tubule, but you also have upregulation in the collecting duct, where sodium is exchanged for potassium and protons. This is how you develop the hypokalemic alkalosis. And that's why fractional excretion of sodium in patients with salt wasting disorders is typically normal. That is, until they start supplementation. If they start salt supplementation, then of course it will go up, because in steady state, what comes out must be equal to what's coming in. So the other conclusion that you can take from this, he certainly did not take a salt supplement with such a low sodium excretion. However, if you excrete potassium instead of sodium, if you exchange that in the collecting duct, you still need an accompanying anion, and that is mostly chloride. So the fractional excretion of chloride here, 1%, is a much better way to diagnose renal salt wasting than sodium. And when we did a review of all our cases of Bartter and Gitelman syndrome, we saw that all of them had a fractional chloride excretion of at least 0.5% at the time of diagnosis before they started supplements. But what now? Back to this patient. Here we have this patient with Gitelman syndrome with actually rather okay potassium of 3.3 electrolytes, but who is severely symptomatic. And this is really a problem. Initially, Gitelman syndrome has always been poo-pooed as sort of a minor disorder where patients, yeah, they have these electrolyte abnormalities, but they don't have really many problems. But then more and more research indicated that some of these patients at least have quite marked problem, and it leads to quite marked deterioration of quality of life. And some of them are really very symptomatic. So they're unable to work full time, they have severe fatigue, they have these recurrent cramps. But the problem is there is never been found a correlation between the severity of the symptoms and the severity of the electrolyte abnormalities. So in my own experience, I have patients who are walking in happily without any symptoms with a potassium of 1.5, and other patients like this boy with a potassium of 3.3 who have very severe symptoms. And this, of course, is a problem. In our KDIGO consensus paper on Gitelman syndrome, we recommended to try to achieve a potassium of 3.0, but also realized and acknowledged in that paper that this would be very difficult in some patients. And the usual problem that we have is that we get these abnormal values, we start or increase supplements, we act, we are rescuing the patient, we're treating the patients, we may repeat the blood test later to ensure our action has worked, and then because it's still low, because they still have the salt wasting disorder, they're still losing the potassium in the urine, you increase the supplements, but it's still low because you're just making the urine more expensive because it's all lost in the urine, and you retest, and then you have this escalating spiral of ever increasing doses, just like it happened in this boy. And the most important question, I think, in those cases that we have to ask ourselves is, do we actually treat the patient, or do we treat a number, a blood level? And my clinical impression when I saw him was he was actually fully functional, and yeah, his biochemistries were remarkably well controlled. He must have just taken his potassium supplements prior to coming to clinic. I mean, again, in the KDIGO consensus guidelines, we recommend trying for potassium of 3.0. I mostly fail with most of my patients, but his was 3.3. But the most important thing for me and what I tried to communicate to him was he had Gitelman syndrome since birth. This is an inherited disorder. He most likely has been having abnormal electrolytes and a potassium of 2.6, as it was at presentation, for many years before. But he did not have any conscious symptoms for it. The symptoms really only started once he knew of the abnormality. And that is something that's really important, I think, because it's the importance of context. Because I'm sure he had symptoms before. I'm sure he had cramps or fatigue before. I mean, does any of you ever have cramps or fatigue? I have fatigue all the time, and I also get cramps. Anybody gets that. But once he had seen the panic in the eyes of his doctors in the emergency room, when they received that potassium of 2.6, when they wheeled him up to the intensive care unit, put in the line, gave him doses, repeated blood tests left and right, gave more and more doses, that's when he realized this is a serious problem. And that's when he started looking up on the internet and saw that this is something that can lead to sudden death. And now, whenever he has cramps or fatigue, it's not just cramps or fatigue. For him, that is the first step, and the next step is sudden cardiac death, and that's it. And that's why he is so panicked about it. And that's why he experiences these symptoms now such more dramatically. As pediatricians, we are well familiar with that problem. Think about a patient who's coming for a blood test. Some of these patients, they wind themselves, they work themselves up already days before, and when they come in, they're absolutely hysterical, they're screaming, and when the needle goes in, it is the worst pain ever imaginable for them. And then the next time you get a good play therapist who manages to distract the patient, and you put the needle in and he hardly notices. The same stimulus, a needle going through the skin, but in one context, experienced as the worst pain imaginable, in the other context, hardly felt at all. And I think this is the same here for the symptoms of Gitelman syndrome in this boy. As long as he didn't know about it and didn't think that this had anything to do with the disorder and could be associated with serious problems, not a problem. But once he knew about it, he now felt, oh my God, this could be my life's end. And these symptoms were consequently experienced much more severely. So when I saw him, I thought that my biggest, most important task was to reassure him that this is not a lethal disease. Yes, there are case reports out there of sudden cardiac death or sudden death in these patients, but this is actually typically in patients who then have also extrarenal salt losses, for instance, from diarrhea and vomiting, and but not in normal life, and it's still on a case report level. To what degree this is actually the frequency of such severe complications is increased compared to the general population, we have absolutely no idea. In fact, from clinical practice, the estimated incidence of Gitelman syndrome is 1 in 40,000. From the frequency of these pathogenic or putative pathogenic variants in public databases, we think that the true frequency of Gitelman syndrome is probably more like 1 in 10,000 or perhaps even 1 in 2,500. So most likely there are hundreds of thousands of patients with Gitelman out there in the world who have never heard about their diagnosis and are going through their life without any apparent problems. Otherwise, they probably would have come to the doctor to get their bloods checked. So many of these patients live happily with their abnormal electrolytes unknown because they don't know about the diagnosis. And therefore, I thought, as part of the reassurance, I should tell him to stop his routine supplements, because it's very difficult for me to say, this is not a lethal disease, don't worry about it. but you still better take your 50 tablets of supplements a day. I encouraged him to find out for himself what helps him. So if he gets cramps or if he gets fatigue, try some extra salt supplements, some magnesium supplement, some potassium supplement, whatever works, try to find it out for yourself and use these supplements as needed. I also asked our psychologist to help him to alleviate his anxiety. And thereafter, actually, he did much better. He's back in school. He loves his high salt diet. He comes from a upper middle class family that was very health conscious, that had a low salt diet. And now he can indulge in all the terrible things that his parents never wanted to let him eat, all the junk food, the pizzas. He can really take it in now and tell his parents, but it's what my doctor told me to do. He still has symptoms, of course. He's still complaining about fatigue and cramps, but he can manage it in his daily life. And he takes the supplements as they feel he helps them. And at the last follow-up, these are his biochemistries. So first, in the second row here, when he was first at his local hospital, but when he first came to us and was taking, supposedly at least, more than 50 tablets a day with very expensive urine. And then at this last follow-up, when he was taking no routine supplements, you can see his electrolytes are almost exactly the same. Yes, his potassium is now not 3.3, but 2.9. But most likely, the potassium would have been 2.9 or 2.5 an hour or two later anyway, once the supplements had been peed out. And just so that I'm not misunderstood, just to make clear, I certainly do not want to say that this patient faked symptoms or that they were all psychosomatic. I'm sure he has those symptoms, but how they are perceived varied. The cramps and the fatigue were nothing special before he knew of his diagnosis, but were something very threatening that he felt were very threatening after his diagnosis, and that's why he perceived them so much more intensely. I also don't want to say that we should not give supplements to our patients with these salt wasting disorders. Most of my patients get these supplements, but I do think we need to consider how much we give and whether we should really try to stick to some more or less arbitrary target level, and how much we should really think about treating our patients than a blood level. And with that, I come to the end of my talk. So treatment of these salt wasting disorders like Gittelman and Bartter syndrome is very challenging. When you have tubular dysfunction, your blood results are often at the extreme end of the spectrum with regards to the electrolytes. But there is no obvious threshold at which a blood value becomes dangerous. We have a normal range, but if the upper limit of potassium is 5.5, does it mean that 5.4 is okay, but 5.6 is dangerous? Is 6.0 dangerous? Is 7.0 dangerous? And again, I think this all depends on, is this acute or is this chronic? And a stable abnormal lab result, like a stable potassium of 2.5, may actually be, I think, without any clear evidence for that, but that's my thinking, a stable potassium of 2.5 may actually be safer than someone who takes large doses, intermittent doses of supplements. So if you take a big dose of potassium supplement, your potassium will go up from 2.5 to maybe 5 when everything is absorbed. And then you start excreting it again in the urine. And an hour later, it's 2.5 again. And then you take another big dose and then it's up to 5 again. And then it goes down. So when you have these swinging values, I think that may actually be much more dangerous than having a steady low value. And again, the key message, treat your patient, not a number. And with that, I would be very happy to answer any questions.
Thank you very much, Detlef, for this very interesting talk, and I'll leave the floor to my dear friend Sidharth to check the questions from the audience.
Thank you, Dr. Neveen. Thank you, Dr. Detlef, for the excellent presentation. It's an honor to listen to your talk, indeed. So I think we have two questions from the delegates here, three now. The first question is, how do you deal with factitious use of supplements when these patients come to you?
I'm not quite sure what is meant by factitious use of supplements. Is that the idea that they take the supplements just shortly before the blood test in order to get good results?
Yeah,
well,
exactly.
Again, as I'm not so focused on normal blood results, and as it has no direct consequences in an asymptomatic patient, if they have these abnormal lab results, I don't really provide an incentive for patients to try to fake that, I think. So it may still happen. I don't know. It could very well be. But again, I think if your focus is on treating the patient rather than a number, then it's more trying to listen to them. How are the symptoms? How is your life? How much is the disease impairing? Have you tried taking magnesium supplement when you get a cramps? Does it make you feel better? Or when you feel dizzy or fatigued, have you taken some extra salt? Does it make you feel better? And trying to just work together with the patient and encourage the patient to take control over their own disease by finding out what makes them feel better when they get these symptoms. That, I think, is for me the most important. Trying to give them some control over the disease.
Yeah, very well said. To treat the patient and not the lab test.
Yes, exactly. Yeah.
We have quite a few Q&As here, and they are coming up. So I'll ask an interesting one from Dr. Bushra. She's asked that, are there any upcoming gene therapies coming up for tubulopathies?
I don't know. I don't have any in my pipeline. And I think the vast majority of tubular disease genes have been found. With the modern sequencing method, it is now so easy to get all the genes tested. And the only genes that are now coming out are for ultra rare disorders, where there is 1 or 2 or 3 or 4 patients worldwide. All the other ones, I think, have been discovered. So I'm in this ClinGen group, the initiative to try to ascertain which genes are actually true disease genes, which are false ones, which variants are good, and so on. So we are always on the lookout. Are there any new genes that we need to annotate? But there isn't really anything coming through in the last months, I think, in the last few months.
Okay, thank you. Another interesting question is, do we really need genetic testing in all of these patients, especially Gentleman syndrome in resource-limited settings, if we have made a clinical diagnosis?
I don't think so, no. Of course, I find it very satisfying if you can confirm your clinical diagnosis with a genetic diagnosis. But when we reviewed that actually, and this is a paper that is published several years ago in Kidney International, the genetic diagnosis in tubulopathies, where we had a cohort from France, Belgium, and the UK of, I forgot, 180 patients or something like that with tubulopathies. Almost always was the clinical diagnosis correct. So it was more confirmation of the genetic diagnosis. The most discrepancy was between Bartter syndrome and Gitelman, which are clinically indistinguishable. So that you say it's Gitelman, but it turns out to be Bartter 3 or vice versa. So I don't think it matters very much for that. But of course, for the counseling, for screening of other family members, for antenatal screening, if there are new babies coming, there it's very helpful to have the genetic diagnosis.
Yep, thank you. A question from Dr. Arnaud.
Sorry,
Thanks for the
if I also may
yeah,
quickly
please,
go back to
please.
that. One of the other things of the genetic diagnosis, of course, is with the Gittelman, for instance, there have been quite a number of other disorders identified that can mimic Gittelman syndrome, from mitochondrial cytopathies to some other rare forms. So for that, I think for these exceptions from the rule, less than 10% of all patients with Gittelman syndrome have one of these other disorders. But for instance, I made the misdiagnosis of Gittelman syndrome in a patient who later turned out to have HNF1B. For that, the genetic diagnosis is helpful for these less than 10% who actually put you on the right path. And then you can look out for other abnormalities that are associated with those disorders.
Yeah.
Sorry.
Yeah,
so
you're right. Yeah,
yeah.
You're right. Like even
Yeah.
like there are times like when we find that on genetics, this patient had a distal RTA with the sensory neural hearing loss defective gene, and then we look back and we found that those patients have sensory neural hearing loss as well.
Yeah.
So yeah, genetics does help us, I think, in finding the extra renal manifestations also.
Yeah.
Isn't it?
Yeah, absolutely.
Another question on growth hormone in Bartter syndrome, if the growth is really impaired.
So I come from a unit there in London where we have always been very, very hesitant about giving growth hormone and have done it very, very little. I remember one patient with Bartter 3 who had very severe electrolyte abnormalities, also in this potassium 1.2, 1.5 range, and who had true growth problems. He just did not grow. And I sent him to the endocrinologist to assess him for growth hormone deficiency, and they assessed him, and they indeed found a growth hormone deficiency. And that is reports, also several reports in the literature of specifically Bartter 3 patients who are not growing very well. And he had initially been treated with, I think, indomethacin, but then he developed an ulcer, so we had stopped the indomethacin. He was not on any non-steroidal. And the endocrinologist started him on growth hormone, and his growth was absolutely unchanged. He still was stuck. And then I started him again on non-steroidal, but this time celecoxib, so the COX-2 inhibitor, where you have less gastrointestinal problems. And once he was started on that, once his prostaglandin synthesis was suppressed, he grew all of a sudden much better, while still getting the growth hormone. So whether it's the growth hormone or not. So I think this would be one of those potential symptoms that you get. Is it from the electrolyte abnormalities? Is it from the prostaglandins? I don't know. But if the patient with Bartter syndrome is not growing very well, I would clearly also think about the usual treatment of Bartter syndrome to see if that can make it better. And if that doesn't help, sure, have him assessed for growth hormone and start growth hormone if there is a deficiency.
Thank you. And maybe I'll take the liberty to ask you one of the questions for which I've been bugging you on email since last few weeks about Bartter syndrome type 2. A patient who has antenatally polyhydramnios, but postnatally a normal urine output, but has genetically proven Bartter syndrome. And yes, hypercalciuria is there. So how do we explain that physiologically? Can we explain that?
No, but I think for every genetic disorder, you always have this large spectrum of manifestations. I also remember one patient with Bartter syndrome type 1, actually, where you do expect more electrolyte abnormalities than with the Bartter type 2, because they still typically have the most normal potassium and bicarbonate, because you need the KCNJ1 or ROMK channel also in the collecting duct to mediate the potassium secretion. So I remember one patient with Bartter syndrome type 1, also polyhydramnios, the full works, premature birth, and then later on his electrolytes are always perfect. He has hypercalciuria, he has nephrocalcinosis, he has polyuria, quite marked polyuria, with an impaired urinary concentrating ability. So he has the secondary nephrogenic diabetes insipidus, but his electrolytes are perfect. So it's there. I cannot explain why that is, but I think that's within the spectrum of manifestations that you have with any genetic disorder.
Thank you. Thank you.
Yep.
Just a
Doctor.
quick question, Detlef, please. You mentioned the management before the closing, just a quick question. You mentioned the management with adolescent, the case you showed, the fantastic case you showed. But how you deal with the infants and toddlers and the families as regards to supplementations? I guess many of the audience would like to know your experience in that respect.
Yeah, if you have infants, obviously it's much more difficult to talk about symptoms. There, it would be mostly how do they grow. Since it's a salt wasting disorder, I will mainly focus on salt supplements. However, that can be a problem in those patients with the secondary nephrogenic diabetes insipidus. Remember, if you have nephrogenic diabetes insipidus, one of the most important treatments is trying to limit the osmotic load, trying to limit the salt intake, because the more salt you give, the more fluid they need to excrete. And in Bartter syndrome, you try to maximize it. So those patients with a secondary NDI, they are a true management problem. And in my experience, it's better actually to go low on the salt supplements, because otherwise they become severely hypernatremic. But in those who have retained urinary concentrating ability or just isostenuria, no hypostenuria, I focus on the salt supplements, and I will give potassium or something like that in the milk. But again, I'm not trying to achieve normal values or target values. If the potassium is higher than 2.0, I'm usually quite happy.
Okay, thank you very much. And we appreciate the talk that you've given us today at the World Kidney Academy webinar, the fantastic portraying of how tupules have been underestimated. You certainly portrayed their function that I think no one would ever forget, how tupules are essential in the internal milieu and fluid electrolyte balance. And I think one of the most important things you highlight is that we're treating patients and not labs.
Yes.
So it's a holistic approach. So this doesn't mean we won't treat, but we take it, it's a holistic approach to the patient. We put the pieces together, and you fantastically showed this today to all audience participating in this webinar. So I'd like to thank you very much for this magnificent view of the little robots and the kidney, our tupules. And I'll hand it over to Professor Amr for last words. Okay.
Thank you so
Thank
much,
you.
Professor Neveen. Thank you so much, Dr. Sidharth, Dr. Detlef, for this very nice presentation and moderation. And we really need to know more about these rare syndromes. Yesterday, it just came into my knowledge for the first time that these kids with Bartter syndrome, they have had a chance of having recurrent UTIs. And I was thinking why they have recurrent UTIs. Is it just because of the hypercalciuria? How does hypercalciuria explain recurrent UTI? How often does this happen? Do they have to have kidney stones or urolithiasis for this to happen? So a lot of interesting answered the question, I think. And I really thank you for highlighting the how important to just lay back and not to be very nervous about the numbers, you know. And this is one of the worst decisions we usually take, is to abruptly intervene in something that is happening for, you know, going on for a while, and we do acute changes that might induce harm more than, you know, inducing benefit. So we have to be very wise to take things together and to use the holistic approach, as Professor Neveen said. Again, thank you so much for this very thoughtful, informative webinar, and hopefully we'll see you again in our upcoming webinars.
Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye.